It hasn't been chilled.
I don't believe he has a functional
wine
wine
cellar
cellar.
in 50 years. Yeah.
So he's an, and I don't want to upset him. We did have a bad interaction with him before Mayday because when we repointed the back of our house, a desk came into his house because his windows are exposed to the outside, and even though they draped it with a tarp, right, like the whole process was very upsetting to him. But the state of his property is upsetting to me. So Joey is very friendly to him. Joey stops and talks to him all the time. I talk about this so much. Joey's going to be the one to be like, my mom wants to buy your house.
Yeah.
Anyways,
Well, maybe that'll be like the opener for conversation. Like, quick as that.
anyways, right? That's my fantasy. That's my fantasy.
Right, you could make it, you could fill in the dog later. You could do something very
It would be amazing.
Dog like essentially not really increasing any of the property lines.
Well, so we would be non-conforming exactly for that reason, because the houses are already take up a greater percentage of the lot than you're allowed to. So I would be even
okay.
increasing that. And then also, I would take down his fence and I would park there. So I would have a paid parking space out of this scenario too.
the zoning is currently grandfathered non-conforming courtyard. By right, you're allowed to go lot line to lot line, so you're filling in your lot line.
Right.
Yes, that's what I'm saying. Lot line to lot line. That's what I'm saying. Because everywhere else in the city, you're not allowed to go lot line, but on the hill, because there's a town law. So for us, so like for ours, if we hadn't gone lot line to lot line on our addition, we would have had to go back for it.
It
Even
doesn't
though
mean
oh yeah, no, not that. You're only allowed to occupy 74% of that variance.
So yours actually, so the
You
dog
should be
leg
able to
filling
fill in the dog list. I'm not
is
even
a width expansion.
But to your point is good, which is, no, I know this is not that help out, because I did our representation and then hired a consultant. But
Yeah, exactly.
but the issue is percent lot coverage.
Yes.
Because if that takes you over 74%,
Because it's already non-conforming.
I think that's what it is.
Steve
It's
said
not,
I knew
it's
that.
not the non-conformity, it's the
I
percent
understand.
lot.
Yes. Yeah, but that's a non-conformity. But if it's not a non-conformity
It's not
with
a
a different.
non-conformity, it's a lot coverage. But for us, it created, if you took one grandfather created, so we had side yard, side yard, closed it because we went back, thus creating a non-conformity.
Yes, that's
And it was the new non-conformity that took it out.
that would be our plan. Anyway, big
Are you
plan.
glad you know this?
Big plan.
Actually, well, you're not a homeowner in DC, so you never know when it's going to be helpful.
Here in the Shaw area.
You know, they can make yourself work up there.
That's a nice area.
It is now.
I know. Oh, I hear
It
you.
wasn't when I bought my house. Well, I did it before this.
Exactly.
Yeah, we rented there for a while, and when we went to buy, we were like, well, we can't afford here anymore, so
I know. That's the problem with the house.
maybe more right.
That's why I have to buy my neighbor's house. I mean, I gotta think it's a place. It's unique. My husband's on business.
I just want to make sure I got right.
Probably, it's the one.
Right here, any staff you have with you is welcome to sit back here with you.
Thank you very much.
Water here, would you like any coffee or anything?
No, just
Okay.
the water would
Great,
be
let's
Hi, I'm Jonathan.
Hi, Jonathan. I'm James.
Nice to meet you.
Pleasure
In
to meet
person,
you.
at least.
Hi, Jennifer Bollinger. Nice to see you again.
Very good to see you.
We just had a conversation with Gene in your offices in down on headquarters maybe 2 weeks ago with Seema. So we all went to just sort of do meet and greet introductions. Gene and a few of the Medicare Medicaid guys. So
I have been this room is.
this is such a great room to have a guy. Oh yes, this is definitely yes, this is one of his favorite topics. So and so yeah, but he's actually been really supportive. We've had conversations with him. We just did this meeting with the state auditors on the Medicaid side.
Hopefully we didn't make too much work for
Medicaid
you guys.
education for a number of the state auditors at his request. At the sort of a joint HHS Justice Department facility in South Carolina.
One thing I
So,
can
yeah,
remember more
which
research
that went
is
really well.
how
So
different the
that's-
approaches are when you look at the different types of payment systems and like how like the mindset for one versus the other is very the approach kind of necessitates a different approach that you kind of do. So you have to kind of like really
Yes.
think about
Yes.
setting up an approach to address issues based on like what your right so
I do far better than that.
Well, personally, I mean, I'm really happy to grab the issue in some potential. Because I think it's important.
My office.
So I'm happy you.
Which is
I'm
part of the
so
test.
like
Just
obviously
recently,
like I think as I mentioned
technically I have a Ravi program.
because of the fraud bust
So
I think that it's
we are working on
attract a lot of attention to
it. It's been from Medicare to
which I think is fine, but really like I want to get more stuff on this.
it does.
But that's another reason
us
why I
to
think
have that independent oversight perspective.
Hey, hi, Ron. Hi. I'm Marty. How are you?
This is Mr. Buchanan.
Hey, how you
James
doing?
Cosgrove, it's
James,
my
good
pleasure.
to see you.
Good to see
Yeah.
you too.
Chairman Buchanan, nice to see you again.
Yeah, good to see you.
Jonathan was in with you a few weeks ago.
Right, we were up here about 3 weeks ago, right, with Demetrius, the head of Medicare.
Yeah. So we appreciate you coming.
Thank you so much. I appreciate the invite.
I don't know. I just when I became chairman of the committee, I just thought, let's look at the big stuff. You know, if we can make a dent in it, it's not going after any group or anybody, but you know, if you take a 10% factor on a gigantic program, and it's this or Social Security, it's real money. And if we can start pushing the other direction, so that's the idea today is, you know, what can we do to get better information and start, you know, trying to reduce some of the overpayments and fraud. Keep an eye on it. And how much is that one way or the other? How much is overpayment and overpayments? What do we, what we do overpay, how much do we get back if we have any sense of it? So that'd be another question, you know, to ask, just to get a sense of that.
That's one that we talked about after we met with you last time, and so we'll
Yeah.
continue to work
Yeah,
on that.
just to see, you know, where we're at, and if we can get better on some of this information at some point, because I think it's important information to have. I ran businesses for 30 years before I got here, we had 1,200 employees, and I can just tell you, if we overpaid someone, you know, we're gonna fix that. That's not gonna continue to happen, and then we're gonna make sure that we get, if we do overpay, try to get a credit or get some of the money back. It'd be interesting to know that too, so.
And if we underpay too. And if we underpay, we should also pay.
Yeah, yeah.
Right.
I always tell people, like with veterans issues, they come in and when they've got an issue and they feel like they're not being treated fairly, if we feel that or we can help, we're gonna make sure that they get whatever benefit they've earned. But on the other hand, if we think someone's taking advantage of the system, there's no way. You know, that's the same thing here. If they're eligible and they're supposed to get it, they get it. If they don't, then they don't. But anyway, thanks for coming. Appreciate
thank
it.
you so much.
Yeah.
Thank you for doing this.
Yeah.
Really looking forward to it. It's going to be a very wide-ranging discussion, I think, on a lot of issues. So get ready. I think that, as I was mentioning to CMS, that I think that the fraud bust last week is going to make quite an impact on their interest. So like, you're going to expect to see a lot of that. But hopefully we'll get a little bit of discussion on some of the other issues too. And I think that we will. So really good. So I really appreciate both of you guys taking time. I think it's going to be good. So. I'll let you guys do what you need.
It just illustrates the kind of things that we have going on. Yeah. Yeah, that's what about the HVAC process. Yeah.
Melanie.
I'm Jonathan Morris. It's nice
Nice
to meet you.
How are you? I'm good. How are you guys? Good. Hi, I'm Melanie.
Carissa.
Hi, Chris.
Chris is on the hearing team.
Steve. Hi, Steve.
On whose team?
I'm good. If you need biking, we'll be biking and all.
Yeah.
But you just walk in.
The AC.
It was really nasty this morning.
I've had meetings in rooms like this before.
Well, I saw you walking in and
know,
I was like, where's
staff
Laura?
nurse, and it's just like
They're like hearing related questions.
this room just swallows you up. I don't have it.
Yeah, that's at the end of the day.
Yeah. Remember the old days when we didn't even really have big trucks. And you had to carry them. Yeah. It was such a hassle. That was the worst part of it. Right. Well, some of the printer rooms here, they have some. They just think fast.
Good luck.
Thank you very much.
Do you have water? You have everything you need?
All set.
Okay. You didn't hear that from me.
I feel like I need like a booster seat. Go ahead. I do.
There he goes. There's the boss. Good.
How you doing?
Good, good.
It's
Good to
like
see you.
Georgia and Florida weather.
Yeah. Georgia, Florida.
Sorry, Mr. Chairman.
The subcommittee will come to order. Welcome to the Ways and Means Oversight Subcommittee hearing on the efforts to combat waste, fraud, and abuse in the Medicare program. Nearly 60 million Americans, including 4 million in my home state of Florida, rely on Medicare programs to provide care. We have a responsibility to all of them and to the taxpayers to ensure that care is high quality and that CMS is paying accurate and appropriate amounts to those providing the care. As it stands now, Center for Medicare Services has not been in a position to ensure that that's the case. A couple of weeks ago, I had a very helpful discussion with staff from CMS Center for Program Integrity about their efforts to address improper payments. One issue we discussed is a 10% error in the rate. So just to put that in perspective, the way I look at it, when you got a large program, 600 billion, 650 billion, 10% is over $1 billion a week in improper payments, and that's really what we're talking about. How can we drive that down? So 10% error rate that is reported includes fraud as well as overpayments as well as underpayments. Put directly, that's 10% number doesn't really tell us much about the program's integrity. Problem with accurate and complete documentation makes up a substantial portion, and it's impossible to extrapolate how much of the payments are actually lost to trust funds and how much merely represent administrative errors. CMS treats them the same. When we try to understand how much fraud is in Medicare, the answer we simply don't know. Understanding payment errors is important, as every dollar reported lost in error serves to undermine the good works of the program and could represent a dollar that should be spent on providing care to beneficiaries. However, different types of errors require different analytics and different solutions. Last week, the Department of Justice and the Department of Health and Human Services announced charges of more than 400 individuals who claim more than $1.3 billion in fraudulent payment. Bad actors are real, and it's important that we continue to provide support for the effort to combat fraud. However, errors other than fraud require a different approach. This makes efforts to distinguish between fraud and improper payments important. In the end, we need to look for ways to reduce all types of errors and ensure that the mechanisms created to do this are working as intended. Today, we are looking at how CMS addresses improper payments in Medicare. Over the past decade, enrollment in Medicare Advantage has tripled. A third of all seniors on Medicare rely on it, and this number continues to grow. Because of this, we need to better understand the processes in place to oversee the program and what we can do to improve it. To that end, I look forward to the hearing and the witnesses today. I now yield the distinguished ranking member from Georgia, Mr. Lewis, for the purposes of an open statement.
Good morning. Thank you, Mr. Chairman, for holding this hearing. I also would like to thank our witnesses for being here today and for taking the time to be here. As you know, Mr. Chairman, this subcommittee's work touches many areas, and protecting and preserving Medicare is one of our most important duties. Last year, Medicare paid nearly $700 billion for health services. $700 billion for health services. This program is a lifeline for over 57 million elderly and disabled beneficiaries, and we must ensure that Medicare remains sound and strong for all who rely on it. I deeply believe that preventing fraud is key to this mission. In 2016, the Medicare fee-for-service program paid an estimated $41 billion in improper payments, and the Medicare Advantage program paid about $16 billion in improper payment. We must work together to bring these numbers down. We cannot let the bad action of a few run the promise and commitment of Medicare for generations yet unborn. Yet, as we recommit to fighting fraud, we should be cautious. Our first priority should be to ensure that beneficiaries have access to quality and life-saving services. As Medicare transforms to reward quality instead of quantity, this administration must continue. President Obama worked to fight new forms of fraud, and we must continue to act. We all must continue the Affordable Care Act investment and innovation in preventing fraud before it happens. Reducing fraudulent, wasteful, or improper payment are critical, important parts of keeping the promise to protect the life of the Medicare Trust Fund for all who rely on it. This is not a partisan matter. It is a question of preserving the sacred trust of our seniors, families in need, and people living with disability. It is a question of doing what is right and what is just. And again, Mr. Chairman, thank you for holding this hearing. I look forward to the testimony of our witnesses. I yield back.
Without objection, other members' opening statements will be made part of the record. Today's witnesses panel includes two experts, John Koskov, Director of Health Care at the Government Accountability Office, Jonathan Morse, Acting Director, Center for Program Integrity, Center for Medicare and Medicaid Services. The subcommittee have your written statements, and they will be made part of the formal hearing record. You have 5 minutes to deliver your oral remarks, and we'll begin with you, Mr. Koskov.
Sorry. Chairman Buchanan, Ranking Member Lewis, members of the subcommittee, I'm pleased to be here today as you discuss Medicare program integrity issues. In 1990, GAO first designated Medicare as a high-risk program, in part due to the risk of improper payments. These are payments that were either made in error or for incorrect amounts. Sometimes they may be the result of fraud, and according to HHS's most recent estimate, Medicare improper payments totaled nearly $60 billion. My remarks today will focus on program integrity in Medicare Part C, also known as Medicare Advantage, the private health plan alternative to the fee-for-service program.
Could you speak up just a little bit, please?
Absolutely. Back in 1990, relatively few Medicare beneficiaries were enrolled in such plans. Since then, enrollment has grown substantially, and Medicare Advantage is a popular option. Today, 1 in 3 beneficiaries are enrolled, and payments to plan total about $200 billion. These magnitudes underscore the importance of addressing the 10% of plan payments that HHS estimates are improper. In Medicare Advantage, improper payments largely stem from beneficiary diagnoses that are unsupported by beneficiaries' medical records. That's because CMS uses these diagnoses to adjust plan payments up or down, a process known as risk adjustment, to pay plans more for sick beneficiaries and less for healthy ones. If the beneficiary diagnoses that plans report to CMS are wrong, then plans can be paid too little or too much. To identify and recover improper payments from plans, CMS conducts audits known as Risk Adjustment Data Validation, or RADV audits. In a RADV audit, a contractor checks the medical records for a sample of plan beneficiaries to see if the plan-reported diagnoses are accurate and supported. The first RADV audits checked payments from 2007 for 32 plan contracts. CMS's intention is to conduct about 30 annual audits that would identify any improper payments to a plan based on a sample of beneficiaries, then extrapolate the finding to estimate the total amount of improper payments made to that plan, and finally recover the overpayments. CMS has now additional RADV audits underway for payment years 2011, 2012, and 2013. We believe, based on our work, that fundamental changes are necessary to improve the RADV audits and recover additional substantial amounts of improper payments. First, RADV audits should be better focused on those plans with the highest potential for improper payments. Second, the RADV process must speed up. For a variety of reasons, including a lengthy appeals process, none of the RADV audits has been completed. Third, recovery audit contractors, known as RACs, called for in the Affordable Care Act, should be incorporated into the audit process. The RACs would work on a contingency basis and extend the resources available to conduct RADV audits. HHS agreed with our recommendations, and CMS has begun considering steps to address them, but the details of how the agency will address our recommendations have yet to be filled in. I also want to describe our concerns about the shortcomings in CMS's efforts to validate and use the encounter data that plans must now submit to the agency. For years, MA plans have been somewhat of black boxes. We knew how much the plans were paid and who they enrolled, but very little about the services that they actually provided. Before 2012, plans simply submitted the beneficiary diagnosis needed for risk adjustment. However, starting in 2012, CMS required plans to submit encounter data, which are similar to fee-for-service claims data and contain information on all diagnoses and the medical services and items provided to the beneficiaries. In 2015, CMS began using diagnoses from these encounter data, along with other plan-submitted data on diagnosis, to risk-adjust plan payments. In January of this year, we reported that CMS had made some progress in validating plans' encounter data, but that certain important steps identified in our earlier report had not yet been fully addressed. For example, CMS had not fully established benchmarks for the completeness and accuracy of the data, or had conducted analyses to compare submitted data with established benchmarks. We also found that CMS had not yet established specific plans for using the data for program integrity or other purposes that have been outlined, except for risk adjustment. We therefore continue to believe that CMS should implement our July 2014 recommendations by thoroughly assessing the data for completeness and accuracy, and by establishing specific plans and timeframes for using these data for other purposes. This concludes my prepared remarks. Be happy to answer any questions.
Thank you, Mr. Morris. You're recognized.
Chairman Buchanan, Ranking Member Lewis, and members of the subcommittee. Thank you for the invitation and the opportunity to discuss the Centers for Medicare and Medicaid Services program integrity efforts in the Medicare program. We share this subcommittee's commitment to protecting beneficiaries, ensuring taxpayer dollars are spent appropriately, and identifying and correcting improper payments. As required by statute, each year CMS estimates the improper payment rate and projected dollar amount of improper payments for the Medicare program. CMS takes seriously our responsibility to make sure our programs pay the right amount, to the right party, for the right beneficiary, in accordance with the laws and regulations. It is important to remember that while all payments made as a result of fraud are considered to be improper payments typically do not involve fraud. Rather, for CMS programs, improper payments most often occur when there is insufficient documentation to determine whether the service was medically necessary. CMS's approach to program integrity in the Medicare fee-for-service and Medicare Advantage programs are determined by inherent differences in the programs themselves. I want to spend some time highlighting our program integrity work in Medicare fee-for-service and our approach to Medicare Advantage, and also the cross-cutting work we do with the help of our public and private partners, including our colleagues at the GAO and the Justice Department. To estimate the Medicare fee-for-service improper payment rate, CMS reviews a statistically valid random sample of Medicare fee-for-service claims. Most recently, the Medicare fee-for-service improper payment rate was 11% in 2016. Unlike Medicare fee-for-service, in Medicare Advantage, CMS makes prospective monthly per capita payments to the MA organizations. As a result, CMS uses a different methodology to calculate the Medicare Part C improper payment rate. In 2016, the Medicare Part C improper payment rate was 9.9%. The Part C improper payment rate estimate is based on medical record review conducted under CMS's annual Risk Adjustment Data Validation, or RADV process, where the unsupported diagnoses are identified and corrected as risk scores are recalculated. In an effort to reduce the Medicare improper payment rates, CMS has instituted many program improvements and is continuously looking for ways to refine and improve our program integrity activities. We are always working to more closely align payments with the cost of providing care, encouraging healthcare providers to deliver better care, and improving access to care for our beneficiaries. CMS estimates that through our program integrity activities, Medicare prevented or recovered $17 billion in fiscal year 2015. For example, our fraud prevention system resulted in $604 million in fraudulent payments being stopped, prevented, or identified last year. CMS also recently updated the version of the FPS, which is now called FPS 2.0, which improves our model development time and expands CMS predictive analytics capabilities. CMS also saved Medicare approximately $400 million in 2016 using the National Correct Coding Initiative, or NCCI, edits, which promote correct coding methodologies and control improper payments in Medicare Part A, Part B, and for durable medical equipment. CMS also conducts various medical review activities to help prevent improper payments. For example, CMS uses Medicare Administrative Contractors, or MACs, to review claims submitted by providers and suppliers on a prepayment basis. In fiscal year 2015, MAC prepayment medical review resulted in nearly $5 billion in improper payments being prevented. Overall, these efforts help us to avoid pay and chase, as well as promote provider compliance. CMS and the Justice Department have also developed a partnership with private health plans and state Medicaid programs to fight healthcare fraud, known as the Healthcare Fraud Prevention Partnership. The partnership provides visibility into the larger universe of healthcare claims, beyond those encountered by any single payer. The goal of the partnership is to exchange data and identify trends and patterns that will uncover fraud, waste, and abuse. CMS now has 79 public, private, and state organizations as part of the partnership. And just last week, HHS, along with the Justice Department, announced the largest ever healthcare fraud enforcement action by the Medicare Fraud Strike Force. The takedown involved 412 charged defendants across 41 federal districts for their alleged participation in healthcare fraud schemes involving approximately $1.3 billion in false billings. Over 120 defendants, including doctors, nurses, and pharmacists, were charged for their roles in prescribing and distributing opioids and other dangerous narcotics. In addition, HHS suspended the Medicare payments of 295 providers. CMS also takes seriously our commitment to combating the opioid epidemic and works to address abusive prescribing through data monitoring, information sharing with Medicare Part D, and law enforcement. CMS appreciates the work of the GAO on their recommendations on ways to improve Medicare program integrity. We look forward to continuing to work with them to improve and protect the Medicare Trust Fund while providing beneficiaries with high-quality care. I look forward to answering the subcommittee's questions on how we can improve our commitment to protecting taxpayer-funded dollars while also protecting beneficiary access to care.
Thank you, and thanks both of you for your excellent testimony. We'll now proceed to questions and answer session. In keeping with my past precedent, I will hold my questions until the end. I now recognize Mr. Schweikert.
Thank you, Mr. Chairman. I want to walk through first a couple conceptual things because we were actually trying to take some of the GAO report and make some charts, which probably would have been easier just to pick up the phone and call you. First off, in my fee-for-service compared to, we'll call it the managed care option, it's what, a 2/3, 1/3 mix right now?
That's correct.
If I look at payments in error, doesn't mean they're fraud. Payments in error. I paid too much, paid too little. Most of those sit in the fee-for-service side, correct?
Because of the volume of dollars.
But even as a ratio.
The improper payment rate is fairly similar across fee-for-service and Medicare Advantage.
And the collection side for both an overpayment and underpayment? No, the cleanup, recapture.
On the Medicare Advantage side, let me speak to that right now. That's the intention of the RADV audits. There's a national RADV audit that is done every year to estimate the improper payment rate. But to go into the collection, I was talking about the annual RADV audits that are done. Those began with the 2007 payment year, and when we did our report, I think something like $14 million had been recovered, and more was expected based on the determination of appeals.
And we're right now auditing what year?
We're in 2017, which is why we think these things need to be speeded up.
We're in 2017? So the RADV audit, if I would ask for it right now, saying where we're at, you're actually doing current year?
The most recent payment year that is not going under the RADV audits, I believe, is 2013, unless you have...
Yeah, that's what I was, sorry.
Sorry.
We must have had a miscommunication. So it's 2013 you're doing in 17?
Correct. Yes.
Okay. Now if I were to come back to you and say, all right, those are our payments in error world, and sometimes there's no malicious intent, sometimes it's poorly documented, sometimes it's too much, too little. Okay. In actual fraud, can you help me understand my fraud mix? Something such as, you know, you called it the takedown, but what just happened? How much of this was actually on the fee-for-service side? How much was in the managed side?
For the takedown, I mean, it would be challenging. Most of it would be Medicare fee-for-service. However, they don't think the Justice Department or the Inspector General's office distinguish between how those providers are being
Can you
paid.
speak up just slightly
I don't
for
think
me?
that the Justice Department or the Inspector General's office was distinguishing in how they were being paid. They were looking at Medicare fee-for-service. It could be Medicare Advantage plans. It also could be Medicare Part D, which is the prescription drug program as well.
Is there a disproportionate portion of this that might have been in D? I'm trying to understand where we actually have mechanisms that are working. Why, in some ways in the report, GAO says we should do more audits and then says, but the audits are poorly modeled. You know, I mean, that's actually in your report, saying we need more audits, but the audits have problems. Right. So I'm just trying to work through what my solutions are.
I will say we appreciate the GAO's recommendations, and actually in fiscal year 2015, we released an RFI for a Part C RAC, is required under statute. One of the things that we actually contemplated and proposed to the various stakeholders was changes to the methodology, in part in response to GAO's recommendations. So we are taking those under advisement and are working to implement everything.
Okay, in my last 50 seconds, if I were to ask for just what we have documented as fraud, what is my mix? How much is durable equipment? How much is in pharmaceuticals? How much is blatant miscoding, patients that were never there? If I were to look at what's our areas of fragility, what are we seeing in actual fraud?
We look at, but you know, the challenge from our perspective is we look at improper payments, whether it's fraud, waste, or abuse. Because the challenge with looking at
the question is purely on fraud.
But the challenge with fraud is we won't know if it's fraud until the Justice Department or the Inspector General's office makes that determination as part of the legal requirements. So it's post-payment into the settlement, into the prosecution.
So we're in a world where we don't really know what fraud is until justice actually does their work?
Fraud requires that intent element.
So how do you build a model that quickly reacts to noise in the data systems you tell us you're building?
Sure. What we look at are potential sort of just suspicious payments, aberrant billing patterns, things that would just be outside the norm that we want to flag. But for us to be able to identify if it's potentially fraud, we have to do sort of on-the-ground investigation. We have to collect the medical records. It is a much more time-consuming process.
I'm way over time, but thank you for your tolerance, Mr. Chairman.
I now recognize the ranking member, Mr. Lewis.
Thank you, Mr. Chairman. I want to thank the two of you for being here and for your testimony. Mr. Morris, I want to thank you for your dedication as a career civil servant, as well as the nearly 4,000 other career employees still at the agency. Like many people in this room, I'm very concerned that the administration had not yet appointed a director of program integrity. We need someone at this post to combat fraud, and the position has been vacant for 6 months. Waste, fraud, and abuse must be taken seriously, and it is not clear that this administration has a vision of how Medicare should be moving forward in these matters. From an oversight perspective, waste, fraud, and abuse are very different. While they are all issues of program integrity, they are not the same. So, Mr. Morris, can you discuss the differences between waste, fraud, and abuse, and how to address them through policy?
Sure, I'd be happy to. So we as an agency look at waste, fraud, and abuse collectively, because the challenge becomes for us, we're not really trying to distinguish necessarily between the two. We're just trying to make sure that Medicare is correctly paying, regardless of what, whether it's fraud, waste, or abuse. So we've implemented, the improper payment rate for Medicare looks at just improper payments writ large. And as I mentioned in our testimony, and as Chairman Buchanan mentioned in his opening statement, most of our improper payments are actually documentation errors. About 60% of them are documentation errors, which really means a physician or another provider may have forgotten to sign something that was important for the order that we consider to be required. That doesn't mean that payment was fraud, waste, or abuse. It just means that it was improper. So by our standard, it still is an improper payment, but that service could have been medically necessary. It could have been received by the beneficiary and needed. We are just doing it. We do that as part of our statutory obligation to monitor improper payments. When it gets to waste and abuse, we have a number of initiatives that we have in place that really help us identify what is potentially more problematic. We've got our fraud prevention system, which, as I mentioned at the outset, is an advanced data analytics system, which looks at all of Medicare's Part A and B claims before we pay them, and it tries to identify any sort of aberrant billing patterns and looks for changes in the data, spikes in billing patterns, things that maybe should not be combined in a particular service, and those get flagged for our potential follow-up, the potential auditing of the medical records, an on-site investigation. We also receive numerous complaints from whether it's the Inspector General's office with potential leads, beneficiaries, other healthcare providers. We've got a number of measures around provider enrollment where we very carefully monitor provider behavior. We've got systems that run sort of in the background 24 hours a day, 7 days a week that look for things like whether or not the a felony conviction of a particular provider, whether they've lost their license. So we do a number of potential background checks that look at potential waste and abuse as well.
How do you go about weeding out bad players? There are certain institutions or groups located in one state, or maybe one county, one city, and they just pick up and move someplace else under a different name.
That's a great question. And it actually, it is a moving target, and it is a challenge for us. Because one of the things that we've learned is that as our advanced data systems get more advanced, the fraud schemes have to get more advanced as well. So one of our challenges is to stay ahead of that. We've got field offices in several of the large cities. We, again, do a lot of data analytics work. We do look at a lot of the claims data, identify potential leads. We work very closely with the law enforcement, both at the state level and at the federal level, and really spend a lot of our time and effort trying to identify where those emerging trends might be occurring based on something that we may have seen in one particular area. We could take that data and try to flag it and sort of put that into our different data systems around the country and see if we end up seeing similar patterns.
Well, thank you very much, Mr. Morris. Thank you. I yield back, Mr. Chairman. Thank you.
Ms. Lewinsky, you're recognized.
Thank you, Mr. Chairman. Mr. Morse, according to this report, and many of us are talking about reports today, this is the HHS report, Office of Inspector General, on Medicare Part D and it's on this issue of opioids that you touched on just at the end of your testimony, and I appreciate that. But what I think is interesting about this and draws a red flag for me is one of the things they talk about in here is a prescriber in my home state of Indiana wrote an average of 24 opioid prescriptions each for 108 beneficiaries in a year, costing Medicare Part D $1.1 million just to that Indiana physician. And I guess I am not a health professional. It draws a red flag to me. And I guess my question is, and I know you were probably getting to this on your statement, but what processes does CMS have in place to flag and investigate these suspicious prescribing practices like this? And what do you think needs to be done to improve the system? Because I'm guessing that you're going to say that here's what we do, and then you're going to say, yeah, we need to do more. And so my question is, what is the more? And to have gone through whatever the filters are, to have gone through one doctor in my state to be able to produce these kind of records, I think is astounding. So just from your professional opinion, where do we go on this? What else has to happen? And then what do we need to do as Congress to help you get those filters?
Thank you. We've reviewed that opioid report from the Inspector General's office also, and it is quite concerning. We've got a number of efforts underway in Medicare, both fee-for-service and in Medicare Part D, that try to address opioid prescribing abuses, as well as it's obviously been a major focal point of this administration, of the Secretary, of the past administration. CMS has an opioid strategy that it published in January of 2017 on this very issue, and looking at sort of all the various levers that an agency as a payer can potentially be sort of pulling to help to address the opioid epidemic. From the program integrity side, we have a number of things that we look at. We work with the Medicare program on the overutilization monitoring system. This looks at largely from the beneficiary perspective, but it looks at, does the beneficiary potentially have too many prescriptions? Are there too many, potentially in this case, opioid prescriptions being prescribed in overlapping ways? And how do we kind of make sure that that is not...
Right, but obviously the filters that you're talking about didn't catch this. And so from your perspective, if you had the magic wand and you could say, look, I'm over this, I studied this, I'm the professional, here's exactly what we need to do. Let's at least try this. What would it be? Because the other thing disturbing about this, there's 500,000 beneficiaries with receiving high amounts of opioids. So the filters aren't working. So whatever was done prior to January of 2017 is not working. So we take that off the chart here, and we say that you say, what is it that we're not seeing here, and what can we in Congress do to help you get there?
We have, we also have abusive prescribing authorities within program integrity at CMS.
Do you use them often?
We have used them only a handful of times at this point. Because part of it is we need to be able to establish sort of that pattern in the practice. And when we see a pattern in practice, it often is then referred to law enforcement.
How long is a pattern in a practice? So my, who's your doc here that took this to the limit and over the top? So he's writing an average of 24 prescriptions each for 108 people in a year, and it wasn't flagged.
But when we do see something like that in our data, we flag it for law enforcement. So I mean, that's how those cases begin, though. So in that case, there may have been data that's from CMS in this particular case. There may have been data that is from CMS that we then flag for our law enforcement partners who then begin those investigations. So when the behavior is that egregious, if it's something that we can see in our data, it is something that we need to be able to send to the Inspector General's office, to state law enforcement, to DOJ, and then they begin sort of the more serious criminal and civil.
So what happens now as a result of this report? Because still what you're describing is what's happening pre-2017. As a result of these egregious violations, what new things are going into play now?
Well, we're actually very pleased that the CARA legislation from about a year ago was passed, and CMS is working to implement the Medicare lock-in program. So lock-in is something that's been used very effectively by both state Medicaid programs as well as by private payers to be able to lock in a single beneficiary and a single prescriber. So essentially it helps monitor that overutilization and it helps sort of prevent that sort of abuse from happening.
I appreciate it. Thank you, Mr. Chairman.
Mr. Holding, you recognize.
Thank you, Mr. Chairman. I think we're getting a pretty solid impression that CMS audits are not timely, and this is unfair to both the plans and the taxpayers. So starting with focusing on Medicare Advantage, CMS using the risk adjustment data validation audits, RADV. And so, Mr. Morse, with you, could you talk a little bit about how the audit process works for Medicare Advantage and how often does CMS conduct these audits?
Sure. So happy to do that. So CMS started with a pilot in 2007 where we identify the plans. So we look at 30 plans each year. The plans are then notified for the audit, and they have about 20 weeks to respond to us, then submit medical records. And in order to do that, they've got to go back to all the various providers who make up that patient's medical record and submit the documentation to the plan and then to us. We then begin the review of the medical records and make the determination of whether the diagnoses are there for which we paid the plans. We calculate any payment variation by removing diagnoses that were not supported by the medical record. So for example, if there is a diagnosis of hypertension in the medical record that we've paid pay for the plan, but not in the medical record, we will make a cost adjustment to downgrade that medical record because hypertension was not one of the factors that was mentioned in the medical record. So the auditing process itself takes at least 18 months. We do multiple rounds of documentation review and medical record review, and it's a very sort of thoughtful and time-consuming process for us to be able to go through and make sure that we are calculating everything correctly.
So I have in my notes that the most recent data related to the RADV is from the 2007 plan year, and that currently is under appeal. Is that correct?
That is correct, yes.
So, what takes so long to do these audits, and what is when you go into the audits, what is your goal? I mean, are you hitting your goal as far as the time frame is concerned? And if so, I mean, what is taking so long?
Sure, thank you. Let me take the first part of your question. So the length of time, in part, the 2007 audit was a pilot program. So essentially it was a demonstration as to, thinking through the methodology.
Does it demonstrate that it doesn't work?
Demonstrate the methodology and make determinations as to whether or not it's a fair and accurate way to calculate overpayments. So we did the demonstration in 2007. We then needed to be able to solicit stakeholder feedback in subsequent years to make sure that this payment methodology was going to be accurate and would be one that we'd be able to use going forward. We are in the process of identifying the actual overpayment amounts in 2011, 2012, and 2013. And in those years, as part of the methodology that we determined from the 2007 pilot, we'll also be extrapolating against the findings. So essentially, there will be extrapolated overpayments at that point.
So, I mean, getting to the second part of my question, what do you anticipate is a reasonable time frame for these audits to take place?
We certainly would like our audit time frames to be in the roughly 18 months to 2 years. Just given they're done manually, and they are labor intensive for us to do because it takes clinical expertise to be able to go through the medical record, make sure everything is there, make sure that everyone is reading it accurately and that we agree on the assessment and then make the calculation.
So do you use any statistical software, predictive statistical analysis that can identify and kind of batch these things for you to look at manually?
We do. We use software for both the data collection and getting the medical records in, as well as in order to calculate the overpayments. But the actual review of the medical records themselves has to be done by someone with the clinical knowledge, because you've got to look at a patient medical record and know, is that diagnosis supported by the findings? And that actually takes a real person. We can't duplicate that with just software and data analytics. So there's data analytics in the program, certainly, but that work is actually done by people.
All right, thank you. Mr. Chairman, I yield back.
Mr. Crowley, you're recognized.
I thank the chairman. Thank you for yielding me the time, and thank you for holding this hearing here today. Regardless, I think, of party line, we can all agree that fraud is a serious crime. And given human nature, as our founding fathers recognized as well, prone to corruption from time to time, that as we change the system, there are always those who are looking to exploit or manipulate it for nefarious purposes. I hope we as a committee can use today's hearing to explore what steps HHS and CMS are taking to ensure we continue the progress we've been making to combat waste, fraud, and abuse in the Medicare program. I want to thank both of our witnesses for being here today, for the valuable information they're presenting to us as a subcommittee. Mr. Morse, though the future of the ACA has been in the news every day, I think most people don't realize the extent to which the ACA changed the fraud-fighting landscape in the Medicare system. It gave increased funding to combat fraud, provided new tools to screen providers so that we can prevent criminals from getting into the system on the front end, improved data analytics, and instituted more payment review to check for problems before money goes out the door. Mr. Morris, can you talk about how the Medicare program has improved as a result of these ACA provisions, and what would have been the status of the Medicare program integrity without these tools added by the ACA?
Thank you, Mr. Crowley. So, Mr. Crowley, I would say that the ACA is just one of a number of pieces of legislation, though, passed through this committee that have been actually extremely helpful in us in fighting fraud, waste, and abuse in Medicare. If you look at just after the ACA passage, the Small Business Jobs Act of 2010 allowed us to be able to implement the fraud prevention system, which is the advanced data analytics system that we use. It works somewhat similar to sort of what the credit card companies use to be able to flag potential bad actions or essentially suspicious behavior. The CARA legislation that I just referred to with Congressman Walorski a moment ago allows us to be able to do lock-in for Medicare, which we're currently implementing for the Part D program, so locking in a single beneficiary to a single prescriber. We've got the MACRA has been extremely helpful for us as we're beginning to remove the Social Security number now from the beneficiary ID card. So we do have a number of authorities, even outside the ACA, that have actually been extremely helpful to us.
And I recognize those additions, but I was just focusing specifically because those other provisions are not under attack, so to speak, in the same way that the ACA has been, and maybe we're coming to the end of that attack, but we'll see. Only time will tell. And I'd hate to see these ACA provisions and the program integrity efforts initiated by the Obama administration be reversed. So that's why I was specifically speaking about the ACA provisions as it pertains to attacking fraud and abuse within the system itself. Our witnesses have highlighted the gains we have achieved in combating waste, fraud, and abuse in the Medicare program. Although through the ACA and through executive action, as well as the other bills that you've mentioned, Mr. Morse, at HHS and CMS under President Obama in particular. Our role as Congress should be to strengthen the integrity of the Medicare program, strengthen Medicare Trust Fund, and protect taxpayers from billions of dollars of loss that had played out. So I think it's in the interest of the taxpayer to look at the benefits of the ACA as it pertains to health benefits itself, but these other benefits that are derived in terms of fighting waste, fraud, and abuse. So I thank you all for your testimony today. I thank the chairman for this hearing today. Thank you.
Mr. Mann, you're recognized.
Thank you, Mr. Chairman. I want to thank the panelists not just for your presence here today, but for the important work that you do. I know it's not easy, and you've got a big responsibility. But we are also grateful for allowing us to get the benefit of your experience and wisdom so we can determine how things can be done better. I'm particularly, as some of my colleagues have recognized, we are seeing not only a growth in concern about fraud, but the opioid epidemic, both on the front end with overprescription, but a growing concern about those who have entered into the treatment space and questions about how people are not only being recruited, and I know you don't get into the value of the services, but there are real questions about whether or not the competency of what's being delivered and payment schemes as well. But just in general, a recent subcommittee report from the Permanent Subcommittee on Investigations in the Senate found that only a small percentage of potential incidents of fraud and abuse in the Part D program were brought to the attention of the medic were actually investigated. In fact, the statistics in 2015, there were 8,900 total actionable complaints, yet only about 7% were investigated. In light of the opioid epidemic and the real concerns that have been pointed out here, can you explain why 93% of the cases of potential fraud and abuse regarding prescription drugs did not seem to be acted upon?
So when we are looking at potential fraud and abuse, we also have to look at and balance that with sort of with the burden on the providers. So one of the things we need to be careful of is really describing whether or not it's just fraud and abuse and looking at the prescriber's billing patterns. Anything that is flagged for us that is potentially abusive behavior and really egregious behavior is actually referred often, if it's not referred to the law, whether it's referred to the medic or not, it also goes through to law enforcement, to the private plans to take action. But we also have to balance that with sort of the latitude that we need to be able to give prescribers in their prescribing patterns as well. So the challenge for us is really kind of balancing that fine line of being thoughtful for allowing beneficiaries who often need a certain amount of prescriptions and certain amounts of whether it's opioids or other pain medication to be able to receive those receive that medication following the CDC guidelines that were published about a year and a half ago, with something that potentially moves into the fraud, waste, and abuse area. When it is something that is potentially fraudulent, we do our best to make sure that we flag that either for action ourselves, and often it will be action that's taken by law enforcement, Inspector General's office.
Well, you mentioned you mentioned some standard there. What kind of metrics do you use? How do you calculate where a prescription may be in a volume that's appropriately related to a particular condition versus those who we know are overprescribing, particularly in the opioid area, where we believe the prescriptions are not going to a particular recipient, but are finding their ways out into an open market and leading to further abuse?
So the volume question is one that I have to refer to my colleagues in the Medicare program who set sort of the requirements for what Medicare will pay for under certain prescription drug guidelines. So it's not really a program integrity question for me per se. We just then enforce what the guidelines are and what's been set through the Medicare program. And then the Part D plan sponsors who administer the prescription drug program under Part D will do the same for in their programs as well.
Okay, I'm not sure I completely understand that, but tell me if there's a 7% rate right now of investigation, so to speak, does that reflect the complete utilization of the resources at your disposal, or should we be doing more, or is there a more effective way to get at a higher percentage? What's the right balance there?
I think one of the things that we're very much looking forward to is the implementation of lock-in, which allows, as I mentioned before, it's been very effectively used by the private plans and by state Medicaid.
Would you speak on that in the remaining moments? Because the private plans seem to do a better job than the government in getting to the bottom of this. Why do they do a better job? What metrics are they using, and why aren't we doing that with the government programs?
One of the things that we've seen that we've been actually working with the plans to think about is they do a couple of things. One is limits on potential on the volume of potential drugs, and then they use lock-in. The lock-in program that was enacted through this committee under CARA is one of the most effective tools that we've seen and that we're working to implement now. So,
well, thank you, Mr. Chairman. My time is up, and I yield back.
Mr. Bishop, you're recognized.
Thank you, Mr. Chairman. Thank you for your leadership on this issue, and thank you to the panel for being here today and sharing your time with us. It's enlightening, and we appreciate it. Last Congress, I was on the Judiciary Committee, and we were actively involved in addressing the opioid epidemic, and I know that you've heard questions from this panel about that, and it's simply because all of us have had some real concerns in our districts and across this country at the direction of the epidemic and how quickly it's moving. Last year, the House Judiciary Committee equipped law enforcement and first responders with
ways in which to deal with on-site with the overdosing that's going on, thousands and thousands of situations where police and first responders had no way to respond. And Congress came up with a plan and a solution, and we provided the community programs resources to enhance diversion programs, lots of great solutions, but there's so much more to be done. And in the midst of all this crisis and what's going on with the news, with the DOJ and the crackdown you've seen on prescription drugs, I know that you're in the heat of this battle as well and doing the best you can to address the problem. Mr. Morse, I understand that in cases where Medicare data finds that the ratio of beneficiaries to providers is abnormally high, CMS has a process in place to set up what you call a moratorium area. And I'm wondering, Mr. Meehan raised the issue earlier with regard to what specifically the evidence is considered to developing something like this. But can you tell us a little bit about how you do that, historically, how you've applied this, and whether or not you've seen an uptick in this process of developing these moratorium areas around the country?
Yeah, sure. So in order for when we thought about doing a moratoria, the concept began from us looking at data around potential patterns of services that were being abused. So whether it's sort of fraud, waste, or abuse, it was services that we were looking at that we were finding some significant improper payments in. Most often, home health, what's called non-emergency ambulance transportation. So someone using an ambulance service that's not going to an emergency room. So often to go to a doctor's appointment in some way. And then for something like durable medical equipment. One of the things that we've found is, by placing a moratorium or a cap on the number of providers in that area, it helps us to limit what the universe is of the providers who are supplying those particular services. In order to make those determinations, we look at the number of beneficiaries to the number of providers both in that area and then in surrounding areas and then also in other parts of the country. Because not every area is going to have, so if we put a home health moratoria in Illinois, for example, some parts of Illinois are more rural than others. So we also look at specific zip code by zip code, what does it look like, making sure that we have enough beneficiaries or enough providers to serve those beneficiaries as compared to sort of any other parts of the country that might be relevant in terms of the size. In some of those states where we've put the moratorium in place, the number of, again, just for home health as an example, the number of home health providers dramatically will exceed what we've found to be helpful and what we think it's been an indicator of potential fraud and abuse.
Can you talk about the history of imposing these moratoria across the country? Has there been an uptick in that, in your decision to do that over previous years?
No, actually, in recent years, the home health moratoria has held fairly steady. We have increased them. The home health moratoria has been increased from a county-based system to a state-based system, so they are statewide in 5 states. And that in part because we were finding that home health organizations were setting themselves up just right outside the jurisdiction that we were putting the moratoria in, and then essentially just eluding the idea of the moratoria. So we put them in statewide where we thought that the number of beneficiaries would still be, or the number of providers would still be sufficient for those beneficiaries. But otherwise, they've largely held steady the last couple of years. We've found them to be an effective method of at least capping that number of suppliers and providers in that area. Because often the concern otherwise is if there's a huge uptick in the number of providers and suppliers in any one particular area, and there's a limited or finite number of beneficiaries needing the services, does that potentially contribute to some fraud or abusive behavior?
Thank you for your efforts. We appreciate it. Mr. Chair, I yield back. Mr. Cabello.
Mr. Chairman, thank you very much for this hearing, and I thank the ranking member as well. This issue is of critical importance to my community in South Florida. Most people know South Florida is one of the most beautiful parts of this country, a lot of hardworking entrepreneurial people, but we have another distinction which isn't as attractive or as desirable. And I will just read the first line from Miami Herald article published recently. With federal agents leading Medicare fraud busts nationwide, and in the nation's Medicare fraud capital of Miami last week, a drug-dealing Miami doctor pleaded guilty to conspiracy to commit healthcare fraud, $4.8 million. Now, the people of my community are sick and tired of having this reputation. And people in my community ask me, how come Visa and American Express and MasterCard can prevent fraud, yet we're always reading about the Medicare fraud that is being chased in the newspaper? And I want to know today from both of our witnesses if there's any more authority that Congress can give CMS to remedy this situation. By the way, Mr. Chairman, I'd like to submit for the record this Miami Herald article and the corresponding DOJ press release. And we're very pleased. We are very pleased that there was this massive Medicare fraud bust all over the country recently. But that is an indication of a far greater problem. And this is what we're catching. We can only imagine what we're not catching. So I want to know, Mr. Morse, is there anything else that this institution can do to empower you to focus more on prevention so that we can hopefully stop reading all these articles about chasing fraud and putting people in jail?
Thank you for that question. Actually, this institution has done a fantastic job of doing that already. The Ways and Means Committee has increased HCFAC funding for Medicare in recent years. You've given us the authority, actually, as you talk about credit card, the ability of credit cards to find fraud. We use actually a similar system from the Small Business Jobs Act of 2010, which allows us to do very advanced data analytics and identify potential patterns of fraud and abuse there. We've found that to be extremely effective. That program alone has saved over $1 billion in the last 2 years in terms of prevented dollars before they go out the door. One of the challenges that you speak to, though, is the complexity of actually detecting and preventing fraud, because a lot of it takes on-the-ground investigations. It takes looking through a medical record from a provider, making sure that that medical record actually meets what the beneficiary actually received in terms of the services or needed in terms of services. And that often is, it's labor-intensive, it's potentially burdensome on the providers, and we very cautiously balance that burden with our investigative work. But we've actually been very appreciative with everything the committee has done. Even most recently in MACRA, removing the Social Security number from the beneficiary ID card in Medicare is going to help us along identity theft. We have a number of authorities that we found to be extremely helpful, and we continue to do better and to continue to make progress going forward. But
so, Mr. Morse, you don't think there's anything we can do on the front end as these potential providers, candidates to become Medicare providers, are applying? Because I hear from legitimate healthcare providers all the time, the easiest thing to do is to set up a Medicare fraud scheme because you automatically get approved. Now, you've told me here today that it's a burdensome process to get approved as a Medicare provider. How do I reconcile that with what I'm hearing from healthcare providers back home?
We've got a number of provider screening requirements that are already in place. So we screen for whether or not the provider is potentially a felon or they have any sort of felony conviction. We make sure that they are properly licensed in their jurisdiction. And then we also do, even if they are enrolled, we do continuous monitoring in the background. We have data systems that actually do that electronically without actually any burden on the provider. The provider doesn't know that this is going on, and we are able to kind of look and make sure that that provider is maintaining their compliance with our program standards. But we will then take action if we find that there is any potential abusive billing or any issues that arise from that provider's behavior.
Thank you, Mr. Morse. And Mr. Chairman, I want to thank you again. Whatever it takes, I think this committee, this Congress, needs to empower these agencies to remedy this situation. For taxpayers, for Medicare beneficiaries, it's very demoralizing to read on a weekly basis in Miami these articles about people running these schemes that have cost the taxpayers billions and billions of dollars, and by the way, threaten the solvency of Medicare, Social Security, and many other of our entitlement programs. I thank our witnesses. We need to do much better. Thank you, Mr. Chairman, for this opportunity.
Yeah, I want to thank our witnesses. Let me, a couple of questions. When we talk about a number of 60 billion, is that a ballpark? Could it be 80 billion, 90 billion? Do we really know what that number is? I mean, is that just an estimate?
Thank you. Actually, so building on the conversation that we had with you a couple of weeks ago, it really is an estimate because we are required under statute to estimate improper payments, and there's the IPERA legislation gives us guidance in terms of the things that we need to be able to measure for improper payments. So, especially on the fee-for-service side, a lot of that improper payment error rate of that 60 billion, roughly 43 of it is Medicare fee-for-service. Of that 43 billion, about 60% of that is documentation errors. So for us to look at that—
What about the other 40%? What happens there?
The other 40% is potentially more suspect behavior, and it's more challenging for us to make those determinations, in part for the—
So it's an overpayment, but it might be not put in the category of fraud.
That's the challenge, yes, is making those determinations over at that time as to what constitutes the overpayment. Is it potential abuse or fraud, or is it simply just an overpayment and something that Medicare otherwise should have paid, even if the documentation didn't line up at the time?
Medicare pays out a lot in terms of overpayments. What do they get back? Do we have any sense of that? Any sense of that number?
We've prevented, well, we look at the improper payment rate as just an estimate. So the improper payment rate is just it's a random sample of a number of claims. We, from the program integrity side at CPI, have a number of initiatives, many of which have been through authorizations from legislation from this committee, look at our potential return on investment. In the 2015, we determined that we prevented or identified about $17 billion in improper payments to Medicare alone. That's almost all Medicare fee-for-service.
So when someone mentioned earlier, one of the members, about auditing and going back 4 or 5 years, what's the likelihood of collecting anything when you go back that far?
But it's our duty to go back that far regardless. I mean, the challenge is making sure that the trust funds are able to recover the dollars to the extent that we can that have gone out the door.
Is the $60 billion number, is that a number, what was it 3 years ago or 4 years ago? Has that number climbed? Has it stayed the same percentage? The program's increased. Is it just, you used just a standard 10%? Is that what it historically been, or did it used to be 7 or 8 and it's gone to 10?
Medicaire's, the fee-for-service and proper payment rate in Medicare has actually come down in recent years as we instituted a number of provisions. So 2 years ago, it was just over 12%. This past year, it was 11%. So we are working to obviously get it as low as we can be, because really it's too high even from our perspective.
One of the thoughts I have is that there's a saying, if you can't measure it, you can't manage it. And we need to make sure we've got good, accurate information the best we can in terms of the trend lines and where all this is going, because obviously 10% of a huge program, $700 billion, someone mentioned $650, that's $70 billion a year in overpayments and fraud. That's outrageous. That's why it caught so much of my attention, these big programs, Social Security and Medicare. It doesn't take a big percentage to get to a gigantic number. And that's why I think we need to, put whatever resources we can to take the trend line and move it in the other direction. What could we do as a committee or in terms of policies to help get that number moving in the other direction? Because I'm concerned. I mean, that's take a number of 60 billion. Let's say we're still out of pocket 20, 30 billion. Net. That's still way too much money that could be used for other things.
We appreciate everything this committee has already done. Even in the time that I've been at CMS, a couple of years that I've been at CMS, Ways and Means Committee has increased our HCFAC funding, the Healthcare Fraud and Abuse Control Account funding, which is the funding source and authorization for a lot of Medicare's program integrity dollars. The macro legislation has been extremely helpful for us. The Small Business Jobs Act has been helpful for us. The CAR legislation. So we actually feel as though the committee has been extremely supportive of program integrity work.
Yeah, one thing I would just stay in mind, because it's such a big number, is we need to have a mindset of continuous improvement. It doesn't matter what the number is, until it gets to zero, which it probably never will, obviously. We need to be moving in that direction. Mr. Costco, what's your thoughts on what we could be doing better or different? What could we do as a committee to help you guys be more successful in getting that number down, that percentage down?
I think, GAO would say that CMS has made a lot of improvements. We've made several recommendations to CMS that they need to do a better job in cases of setting objectives and monitoring performance, so that for the activities that are underway currently, they know how well they're working and how they can be improved. One recommendation that we put into our high risk report was in help to try to move past pay and chase is to do more prepayment reviews before the money actually goes out to the provider. Currently, the prepayment reviews are done mostly by the MACs, by the Medicare Administrative Contractors. There was a demonstration whereby the recovery audit contractors, who typically do post-payment reviews and collect fees on a contingency basis, did some prepayment reviews. We think that we recommended that CMS seek legislative authority to allow the RACs to do prepayment reviews. We think that prepayment reviews are more effective and efficient than trying to collect the money later on, and that this would add additional resources to this battle against improper payments. So I think that's one area to consider.
I think that's
the RACs to do prepayment
that's something
reviews.
we should look into. I think anybody knows in business, once the money goes out, it's tough, especially if you're going 4 or 5 years later to get it back. So if you can prevent it going out, if it's something that's legitimate, a service or equipment that's been provided, it's different, but it is not. Okay, well, let me just close with, I'd like to thank our witnesses for appearing before us today. Please be advised that members have 2 weeks to submit written questions to be answered later in writing. Those questions and your answers will be part of the formal hearing record. And with that, the subcommittee stands adjourned.